Hollywood Squares. I mean, I'm sorry. It's the Monday Compliance Roundtable on the Compliance Guy. As always, I want to begin by saying thank you all so much for tuning in, logging on, and just hanging out with me and my friends for a little while as we get to talk about all things coding, billing, auditing, and compliance. But mainly the things that really irritate us the most. And no, I'm not talking about politics right now. I'm still talking about the world of coding, billing, documentation, and compliance. So today I'm so fortunate because we get to expand our normal compliance roundtable, and we've invited a couple of my really good friends, Christine Hall and Terry Fletcher, to join both Scott Kraft and Stephanie Allard, who is still trying to figure out how to work a camera. But with that said, we have a great agenda. We're going to do our best to get through this in about 40 to 45 minutes today because we know that at 5 o'clock at night, y'all have better things to do than to be sitting around listening to us talking about coding, documentation, and billing stuff. But until then, I think we have some great information for you. So I want to go ahead and start by talking with Christine first. One of the issues, and again, I'll date myself. I've been doing this now for 28 years at the end of this year. And since I've gotten into this world of fun, Modifier 25 has always been a modifier of issue. It was at issue with the Thomas Love settlement, if some of y'all remember that from several years ago, where Blue Cross Blue Shield had to, as part of their settlement agreement, agree not to arbitrarily deny services when they were billed with an evaluation and management service, a Modifier 25, and another minor procedure or service on the same date as that E&M service. But the Modifier 25, it's just like the gift that keeps on giving, right? It's like Aaron Boone of the New York Yankees, the manager, right? He is the gift that keeps on giving to the Boston Red Sox. Now, Scott, hold tight, and we'll give you a minute to opine on that in just a moment. But Christine, let's talk about what's going on in the world of Modifier 25 for a little while.
Well, I got to tell you, I've been struggling a lot with Modifier 25 in this most recent audit that I happen to be in because it's on absolutely everything. It's on things that it doesn't even need to be on. And we were talking about this earlier. Somebody had said, but that's the way we always do it. Or the other thing I hear is, that's how we get it paid. Wait a minute. Do you even understand what Modifier 25 really means, right? What are we looking for? From an auditing perspective, I'm looking for a new plan of care or a change to the plan of care. Something needs to happen today in order to decide whether or not we're going to actually do that procedure or not do that procedure. I'm looking for a change there. Options. I'm looking for something else. No, it's still very clean cut. I think, Scott, you said it. They do a UA on the same day as an evaluation and management, and there's a 25 modifier. Wait a minute.
It's that habit of putting it with everything, right? You know, it's like an American diet, like potatoes with everything, right? So Modifier 25. You know,
oh my gosh, that's going to be my new hashtag line. You want fries with that? Modifier
exactly
25.
right. So you put it with everything, and I think, to your point, two problems happen. It ends up on services where it does not belong because there's no discernment about whether it's appropriate to bill an E&M service, and it ends up on services. It ends up on E&M services for which it's not necessary to use it to get everything on that day's bill paid.
Well, and they also forget the whole definition, the first three words: significant, separately identifiable. Significant. That does not mean a level 2. It doesn't mean a level 1. It means significant. So, you know,
Well,
they forget
and that's
part.
a great point, Terry. And I know it goes back to one of your favorite, sayings, Terry. Well, we've always done it that way.
Yeah. We've always done it that way.
I mean, what do you mean we're doing it wrong? We've always done it that way. Well, what do you mean you've always done it that way? How long have you been doing this? Oh, 15 years.
Right.
Fantastic. But,
Or they patronize you, Sean. They go, no, wait a minute. But that's how we get it paid. The insurance company wants us to put it on it so that we get paid.
Listen,
now, in defense of some of our coders, then now I'm going to age myself over 30 years in the industry. I don't know if any of you remember black box edits. Remember those?
Of course,
So-
the NCCI edits that were
Yeah.
released by McKesson HBOC.
Yeah, so those were basically surprise edits. They didn't even tell us. That's why they were black box. We couldn't access them. We didn't know what they were.
Right.
We found out when we got our EOB that, oh, guess what? It's not paid. So I think people still are in that stigma of putting it on because it was such a protection of the E&M along with the procedure. But one of the things I find from an auditing perspective, and this is where it's really tough to educate, the CMS rules and the OIG, because they always have it on their work plan, it seems, they're not clear. They talk about the 25 modifier saying that it has to be significant. You have to show that it's different. And, to Christine's point, show me that it's something else above and beyond the pre and post work of the minor procedure. But the problem is that in the same context of it has to be separate, it also says, but you don't need different diagnoses. But, you can still bill it as long as you can show it's significant and related. But don't try to do it with a new or established patient if it's not related. But they don't give that clear definition of what that means. So you're making it up
You're
as
right.
you go. You're making
Carrie,
it up as you
the
go.
OIG listed last year for dermatologists. They called out dermatology specifically and
They
said,
did.
but you're right. But the explanation now that I'm running it in my head was, we have seen an overutilization that was not supported. Bam. It was 2 paragraphs. It didn't say what, why, how, what procedures. It was very unclear.
Well, I think what everybody needs to keep in mind is just like the Modifier 59, and I thought it was very unique what the Centers for Medicare and Medicaid Services did by creating all those X modifiers. But the Modifier 59 and the Modifier 25, to me, those are red flag modifiers. For years, Terry, and you probably remember this, and I won't bring up any of the names of the seminar companies where I heard this over the years. But people used to call it the golden modifier, right?
Yeah.
They called it the golden modifier. And when you'd say, well, why is it the golden modifier? Well, it will bring you piles of gold if you use it. Well, think about this. Terry talks about this, but, back when I was with Medical Management Institute I started with them in 95. So in 1996, I was actually out on the road and I was in Baltimore. I was in the Inner Harbor at the Omni Hotel, Inner Harbor. And at the midpoint of my presentation, I had an individual walk up to me. They handed me their business card. I looked at it and I went, oh boy, I'm so glad I haven't gotten to the modifier section yet. And it was an agent from the Department of Health and Human Services, because back in the 90s, they started sending agents, both from OIG, from CMS, and from the Federal Bureau of Investigation, out to all of these seminar companies in healthcare.
That's how I became an auditor for Medicare.
That's right.
Because they came up and said, we like your information. By the way, we're not from this doctor's office. We'd like you to do some audits. I'm like, what? That was in the 80s? No, early 90s.
Mine was in 96. And I remember probably about a month after that happened to me, I remember reading something that one of the other consultants, I want to say it was John Burns or Gary Lucas, had provided me in the USA Today. And it was this big expose on how they were cracking down on seminar companies back in the mid 90s who were providing information to physicians to quote unquote optimize their reimbursement. And, using terms like optimization, maximizing, very, very bad terms. You got to stay away from using those terms when it comes to reimbursement for physician services. But to kind of wrap a bow around the Modifier 25, there was a big announcement from Cigna that they were going to be requiring everybody to submit documentation to a dedicated fax number. And if you failed to upload that information, I believe it was supposed to start on August 13th, if my memory serves correct. And if you failed to upload that information after the start date, or what they call the go live date, that you would automatically be denied for the E&M service because it was not substantiated. Now, Terry or Christine, what has happened since they released that from
Well,
Cigna.
Terry and I were talking, and I think Cigna now put a hold on that, but there's a couple of other payers that are moving forward. Which
With that
payers
same
were that,
thing.
Terry?
Blue Cross Blue Shield of Arkansas, the Blues, I think it's Massachusetts, another Blue Cross that has a specific name, but I don't know the state. And then a couple of the United Healthcare. United Healthcare is always in the mix. They love
Right.
doing that. But Sean, one of the things I wanted to bring to the listeners' attention, or the watchers, I guess. Hi, Stephanie. We're so happy to see you now. One of the things that has come up that we've on the 25 modifier, and this is not just with audits, but kind of what we're seeing in the industry. And this is where I think people need to understand this. With every minor procedure, there is an evaluative part of the RVU. So the fact that let's say that the patient is scheduled to come in for a lesion removal, okay, or a skin tag removal or whatever. And the doctor looks at it again. Maybe it's gotten a little worse, and maybe it hasn't. It's a little irritated. And they say, "Are you ready for this?" Okay. And they have a brief conversation. And then afterward, they give them information on how to take care of it and, hygiene, things like that. You can't charge extra for that. That is part of that minor procedure. Now, if the patient came in and said, "Oh, by the way, I've had also issues with my arm ever since I had an injection a couple of weeks ago, and I'm noticing a discoloration. Is this the same thing of what I'm dealing with on the left side you're going to remove today?" And that patient also is saying, "And I started a new medication that gave me a rash." Now you've got an argument for a separate identifiable E&M service. Second thing, and you can absolutely support a 25 modifier. But the second thing I'm finding, and I don't know if you guys deal with this, what you get paid versus what you contracted to get paid are two different things, meaning in your mindset. Just because you don't think the minor procedure is worth enough doesn't mean you can add an E&M so that you can bump up how much you get paid. It doesn't work that way.
That's such a great point.
You signed a certain contract, even if the payment is terrible, which a lot of them are compared to, if you're assessing how much staff time, what it takes, your expense. You may not like the payment, but it is what it is. You either sign the contract or you're accepting Medicare, and you can't add a visit or upcode. And upcode is a huge legal term. Sean will know that. I get that in arbitrations all the time. Attorneys love that word. But you can't add it on just to beef up how much you get paid. That's a problem.
That's right.
I had a provider education.
Christine.
Oh, sorry, Sean. I had a provider education last week, and I asked the provider, now when you go in to do that procedure, do you just get the patient's name here, run in and go do that? Or do you stop for a second, grab the chart, look at the labs, look at the imaging, what's the age, what other chronic conditions? And they said, yeah, that's what we always do. I said, so how is that different? How does that, as a significantly identifiable evaluation and management visit, you wouldn't run in there just with your scalpel in hand and go, okay, I'm here, let's do it. You do, you review that. We're talking about beyond that, beyond what your comfort is to go in and perform a surgical or any type of procedure or additional service with that patient.
Yep.
And when that was the moment that the light clicked with the provider. Yeah. But we've got to make sure that the coding staff also realizes that they understand it now. Does the coding staff understand? Modifier 25 is just not supported.
Well, the other thing before too, and Scott, I wanted you to chime in on this, is we're talking about the attachments as far as the documentation that a lot of payers are requiring. What about the 50% reduction? That is almost, I would say 20 to 25, maybe even more % of payers. And they're saying mostly on established visits because the minor procedure was planned. And so you're not supporting a different E&M service based on kind of what, Christine and I were saying, is that there's nothing extra that you're doing that's not already built into the minor procedure.
Yeah, I try to say it a couple of ways. The thing that I would say about this proposed payer solution is it's terrible to the extent that it's going to cause a behavioral change that will just create different error types in a way, because I think it will result in some deterrence of the usage of Modifier 25 when it's appropriate, right? The idea is to do it correctly, not to just have a hit or miss policy. I try to always say to the providers that I work with, whether it's the coders or the physicians themselves, that whenever you assign a modifier, The checkpoint is that you are deviating from the normal process. That this is not that the modifier is not the normal process, even as you may do it at a heightened volume based on your practice pattern or service type. I will sometimes work with providers where I will say to them, based on the clinical circumstances of what this note is saying, you should have justification for an E&M service with modifier 25. So this is a patient you've never seen before who's having something done, but you didn't document that. Whether that was something that occurred at check-in, you didn't document it in that way. So here's a patient that just, you have seen for the first time. Maybe they've seen somebody else in the practice, but you're going right headlong into this procedure, but you haven't done the work to document it. So there's always different ways to look at it. And I do keep coming back to making that point. Like when you write that modifier down, when you insert that modifier, you are saying to the payer, this is different. So it's the act, right? Like the passive thing. So it gets you out of that ability of your defense being ignorance, right? Because that's the active action, is to append the modifier. Like the passive action is to do nothing.
It's the first sentence in Appendix A that tells you why we have modifiers.
Exactly.
That's right.
It's
to
not
modify
changing the CPT, right?
That's right. It's to modify the definition of what's transpired during the course of the service or procedure. It's plain and simple. And I tell, providers all the time, ignorance is not a justifiable defense, right? Because ignorance, right. Ignorance means deliberate ignorance or reckless disregard. And those are two terms that the government absolutely loves to throw out under the False Claims Act. So, Scott, while we're with you, and I see your Las Vegas Golden Knights shirt.
Certainly wasn't going to wear the Yankees one today.
Not feeling the Yankees today?
Not today, but for the course of the season, yes.
All right. So, and I know Terry loves sports. I know Stephanie enjoys sports as well. Christine, you a sports fan?
I don't know. I didn't watch the Red Sox at the Super Bowl. I don't know who got the Heisman Trophy.
That sounds like a yes.
Oh boy.
Oh no. Okay, Christine, and you're out.
Unfortunately, we can't cut that out. But there is a show.
I think you need to leave that in.
Yeah, the Red Sox and the Super Bowl. There is a show out there that's called The Weakest Link, and I think Christine, you are the weakest
Christine,
link.
you're a Jeopardy contestant who knows nothing about sports. That was really funny.
No, it's true though. Nothing about sports.
And Scott, I just want to rub it in. The Pirates definitely split the Yankee series with you. Sorry, just.
Yep.
All right. It's been a tough run, and I know this isn't a baseball podcast, but I will admit, for the benefit of everybody, that on my way to Ireland a couple of weeks ago, we made all these plans to be in New York for one day, and I'm like, I'm going to buy a nice ticket and I'm going to go see the Yankees, and they got no hit, and I'm like, well, on the one hand, you don't get to see that very often. On the other hand, I wish it wasn't today.
They used 3 pitchers in that game, if I'm not mistaken.
Right.
Yeah.
All right, so let's get back to the stuff that our viewers care about, and that's interpretations. Scott, I know you've been looking at a lot of charts, as has everybody else on the panel. But one of the things that I think you've been noticing is problems with the physicians taking credit for things under an interpretation that's already been claimed as credit somewhere else. Can you elaborate on that and clear up this misconception?
Sure. So I think sometimes this is a byproduct of templates. Sometimes these are things that are lost in explanation. But under the 2021 guidelines, well, sometimes when I talk to providers, I take a step back and I say, let's talk about what the word independent means. And let's talk about what dependent means, right? So I will see things in documentation where the provider is stating, I independently reviewed this X-ray, or I independently reviewed this MRI, and my findings are this. And I will say in the worst case scenarios, I'm like, well, you're also billing for that as part of this visit. So I'm not sure how independent that is. And the wrinkle of these guidelines in the data complexity component of the E&M visit was the notion that rather than having, radiologic be considered one entire thing, where whether you order, 1 or 5, it's one piece of credit, you're able to count your individual orders. The trade-off for that is once you get credit for that order, you do not get subsequent or separate credit at a later visit for the review of the same thing that you ordered. So what will happen is, as part of the provider's verbiage, they will say, I independently reviewed this X-ray or MRI. Now, it's easy for me as the auditor if they billed for it. I'm like, well, that's the easy part. If they didn't, part of an audit, from my perspective, is the thoroughness of the work. So I'm going into if I'm in the EMR, I'm going into the hub, or I'm going into where I can track the orders and say, did you of one of your same specialty, same tax ID colleagues order this at the patient's previous visit? And now you're circling back to it. And I see it with labs. I see it with all types of things where the provider says, well, I reviewed these labs from this date as though they came from somewhere else. But you go back and you look and you say, well, that's the last time that the patient was here that day. And, independent is intended to be for circumstances where those items were ordered by another provider, not same specialty, same tax ID, and they're being brought for you for your review. This could be circumstances where a patient has, say, an orthopedic injury. They go to urgent care. Urgent care does an MRI, and the patient shows up at the orthopedist with the MRI. Now we're talking about an independent interpretation. And I think that's a commonly misunderstood thing. And I think my biggest guidance to the auditors is as I was saying earlier, and I say on calls sometimes, I have a journalism degree from back in the day, and one of our old journalism sayings was, if your mother says she loves you, check it out. And if the provider is saying in the note, I independently interpreted something, check it out. Make sure that it is independent by the definition of the guidelines, because otherwise we are putting things through that are going to create a downstream risk.
Mm-hmm.
Yeah, let me add to that, Sean, on
Go
data
ahead, please.
points. Yeah, so on data points, I'm finding the same thing that Scott is finding, but even to the extent where people aren't reading their guidelines. And again, you need to read your notes, because one of the things, and I know Christine and I have been frustrated about this, Stephanie, you might be as well, even Scott too, in your auditing, when we moved away in the office from 95 and 97 guidelines, they didn't give us an audit tool. So we've had to create kind of our own audit platform, if you were, or audit reference guide. We don't call it a cheat sheet. Never call it that, people, but our own reference guide to be able to pull the information and figure out, are they doing what we said? And we've got these, pages and pages of things. But one of the things on the data points, actually a couple things, is that if you order a test on one day, it's clear in CPT and CMS agrees, and then you are reviewing it on another day, and this is something you didn't charge for, so not separately reported, you already get credit for it on the original order. You can't get it again because there's an assumption you're going to give that result to the patient. The only time you could get credit for it would be if you didn't order it at the initial encounter and you had a phone conversation with the patient later on, and then you got some records, let's say at some point you saw what was there, you still didn't have enough, and so you called the patient and said, hey, I need you to go for this test, and then they come back in and now you're going over it with them, because even though you ordered it after the initial encounter, you didn't get credit for it at that point. So now when they come back in, you can get credit, but you can't double dip there, is what they say. The other thing is, and I just got an email just now, and this is a good one. She says, do you agree that a person contributing and the reason for another person giving historical information must be documented in order to count the independent historian component? Well, of course. But I think what she was saying as well, because it went on a little bit, she said under the 2021 E&M, I'm seeing a lot of interpreting services trying to capture this independent historian. No. They have to be giving information that the patient doesn't have, not relating information just in a new language so that it can be disseminated by the provider in English or whatever the language is. You can't use that, and I'm seeing that being used as well. Absolutely. So there's a lot of data point issues that are.
Yeah,
go ahead, Scott.
I will say something interesting for me with independent historian. I find myself having, I'll say, spirited conversations with pediatric groups with respect to independent historian. And one of the things that I say as an auditor is I don't like to be the person interpreting things that you are responsible for interpreting. And so to put that into some perspective, I did a survey once when I was speaking to some coders last year, and I said, is it your opinion that a 3-year-old patient can give his or her own medical history without the need for supplementation? And of course, very few people raise their hands. Then I said, well, what is your opinion about like a 13-year-old, right? And
wait. Did people actually raise their hands to say that they believed a 3-year-old could be a...
No, nobody said that they could.
Oh, okay. You said the majority.
Sorry if I misworded that. Nobody said that they felt.
Wait, hold on.
Let me take a step back. Nobody said that a 3-year-old could give his or her own history. However, when the age went up to 13, there was some disagreement in the room. When the age went up to like 10, there was some disagreement in the room. And I said, look, as an external auditor who wasn't in there, I don't want to be the one that referees who can and cannot give their own history. So regardless of what that situation is, I'm expecting you as the rendering provider to tell me that this patient can't give their own history and to tell me why. And one of the little wrinkles of the guidelines that I think sometimes is underutilized is that the physician has some latitude in determining if he or she believes the history that's being given by the patient is a credible history. And so going back to that pediatric conversation, I had one conversation where the provider said, well, of course the parent gave history. She was in the room and the kid was only 15. And I said, well, I'm a long way away from being 15, but as I remember it, I was able to speak in complete sentences. And through that conversation, right, the provider was starting to say, well, a lot of times I have patients at that age who are unwilling to talk, or they're very sort of down, and the parent comes in and says, well, this is what I saw. I'm like, well, that's different, right? Now you're getting into the reason and rationale for supporting the history. And I've even given examples before where you think about, a wife sort of drags her husband reluctantly to the doctor, and the husband's saying, well, I'm really not in that much pain. And the wife is like, he can't even go up a flight of stairs. Well, as the physician, you have to decide who, you have some latitude to describe who the credible relator of information is, but we need to see that thought process and rationale in the documentation and not just independent historian wife,
Well, my wife will tell you she's the only credible historian in our family. And
look,
you guys know my wife, so
knowing both of you, if I were the provider, I would accept that.
Thank you. Stephanie, what do you think?
That was something happened with my dad a few years back before he passed. I needed to take him in for his cardiology appointment, and the doctor said, Bob, have you had a recent colonoscopy? And he's like, no. And I'm looking at him, I'm like, we just took you 2 weeks ago. And he goes, no, you didn't. And so the doctor and I wink, yes, he did. Whisper, whisper. And he wrote it down and he looked at me like, okay, I get it. So obviously there was a little bit of, I don't want to say dementia there, but just lack of memory,
Is it more of, and I like the word credible historian, right? Mm-hmm. But is it more of a contributor to the history as opposed to an independent source of the history?
I think it's both. I don't think you can discount it. I think it's both.
I'm not talking about discounting. I'm talking about from a documentation standpoint, Christine or Stephanie, Stephanie, you've talked so much and I'm going to keep you on mute. But let me actually pose this question to Stephanie for just a second. If I'm a physician and I have Scott and Christine both in the room and I'm trying to get information and Scott's giving me his historical interpretation of what's transpired, but then Christine gives me, some additional information. Am I documenting and taking a credible account from both of them, even though I may be getting some conflicting information? How would you look at that as an auditor?
Well, it comes down to documentation. So many times we meet with providers who are thinking that and scoring it in their head, but then you don't find that information out until you're in an education session with them talking about how there was a variance. So it completely comes down to documentation. I as an auditor would not be looking to determine who's right or wrong, because that's really the clinician's place as they're taking that in. But I do expect it to be in the note if they want credit for it.
And the
Sean,
one
it
thing
also has to be contributory to why
Sure.
they're there.
Right.
Some people
I
try to
look
give
at-
information that's just there. That's not enough.
I think contributory and pertinent, right? Because, and that's in the note, you don't always discern that as well as by explaining it, right? And so going back to some of my examples that I gave, right? If the spouse is just repeating what the person says, if the spouse is just affirming, right? Like, yeah, it happened when he fell off the ladder, right? Like, that's not really an independent history, right? That's just, it doesn't add anything that we can't get from the patient.
Right.
I also look for something marrying that information. Wife says husband doesn't take cholesterol meds. Cholesterol reviewed today, it's 300, increasing medication. They're taking that direct information they got from the wife and they're acting upon it. So it's in that medical decision making. You can kind of see that triangle come together. Wife says, reviewed, increased meds.
And I like that term contributory. So, Stephanie, let me come back to you because this is going to tie into something that I think drives all of us crazy, but especially Terry and I, because for some reason, we just get so irritated about some things.
We just have pet peeves.
Pet peeves. So let me come back
Is that
to
what
you
we're
on
calling
this.
them, pet peeves?
Pet peeves. So let me come back to you, Stephanie, on this, because there's something going on with a distributor in rheumatology. Now, I want to preface this part of the conversation by saying anyone who is in rheumatology, this is not an opportunity for you to change the way that you are coding things. This is not an opportunity. This is not us telling you to use different CPT codes, to use different J codes, to change the way that you're infusing patients or what you're doing for them. I think what this part of the conversation is actually about right here is to talk about the fact that you've got to be careful when you're presented with information from any distributor, from any manufacturer, until you have authoritative guidance from the groups to whom you submit your claims for remuneration. And that would be the Centers for Medicare and Medicaid Services or your commercial payers. So with that said, just generically, Stephanie, give us an understanding of what it is that you're seeing.
So one of the battles that we fought, and we talked about it as a group probably for years now after the LCD came out, was how to bill for different rheumatology drugs. So CMS had come in at some point and said, okay, we consider Cimzia, which is an injection, or Orencia or Simponi Aria to be non-chemotherapy. So you have to bill the 96365, which was a cut to reimbursement. So I've had a situation, I have a couple different rheumatology clients where it's not a distributor, Sean. It's actually an organization, a national organization that puts information out at the state level. But one of the things I found interesting, I just talked to one of my clients about this yesterday, I believe it was. They are not signed up for newsletters or anything from this organization. They just received emails because they're a rheumatology practice. So the information that's going out is basically saying that there's a technical correction in place and that you can continue to bill chemotherapy codes for these particular drugs. Now, we need to stop and pause and again warn everybody. That does not mean that here we're telling you that you can, but this organization is sending these emails out to providers. So it's concerning to me. I personally have not dealt much real time with CMS technical corrections. So I just started to dig to see what I can find in writing. For me, I want to see it in black and white, and I also want to see what's currently still in place. So as I'm looking, I can find nothing from CMS that talks about this change. And in addition to that, I went into the 2 MACs because I have 2 different clients in different states. And I went into the 2 MACs and their policies, their LCD policies are very much active, still saying that you have to use non-chemotherapy. So my concern is that there's nothing in writing. I'm never going to direct a client unless I can see something in black and white. And I have an example too to give really quick, Sean, that's not rheumatology related, but it's interesting how it ties into this. So I had a situation here where one of our other consultants had a client who was looking to expand services that they render in the ortho field. And they had been approached by a company to basically do these injection procedures of substances that are kind of out there, along the lines of amniotic fluid, but not amniotic fluid. So throughout all the research, the doctor really wants the opportunity. The salespeople make it look awesome. Great. You're going to be paid all this money. So I dug further, and from our side, I'm like, this really isn't a good idea. And here's the reasons why. Well, the doctor sent my information to that company, and the director of compliance wanted to talk to me about this. So It was very interesting and entertaining to have this conversation. And what he basically told me is that they were in the process of suing the government because their product is not within the current realm of what the FDA would approve. So they're suing the government, and they feel that they're making headway. And I asked the guy, I said, well, what does this mean at the physician level? This is great for you, but what are physicians supposed to do? His answer was, we suggest that you get fraud insurance. And he basically told me, because he told me, yes. He said to get fraud insurance, and he said that they don't mitigate the provider's risk at all, and it's all their own risk. But they're not going to say any of this during... There's different insurances to cover like the legal costs and things.
Yeah. Is part of this insurance that you get like a cake with a nail file in it when you get sent up the river?
Oh my gosh!
A shiv. You get a shiv.
I'm not kidding.
To me, it's like committing suicide and you don't get life insurance. I had no idea there was fraud insurance.
Yeah. So basically, you pick up the phone and you call. Yeah. So basically, you pick up the phone, you call your insurance broker, and you say, "Hey, I've been contemplating. I'm going to commit fraud, and I would very much appreciate it if you would cover all of my expenses."
Fraud, really? Oh my God!
I'm going to do a little fraud. Can I get some insurance on that?
So we got about 5 minutes left, and
you see how Stephanie didn't talk the whole time, and that's what she gives us. Yeah, she is actually the Hollywood Squares Paul Lynch. She needs to stand up and just like okay. Nice.
Get fraud insurance. That is the takeaway from today's compliance roundtable. All right, Terry, in the last 5 minutes, take us home, because I know that you are still dealing with practices who are relying on old templates to be able to support level 5s.
Yeah. So
the highest levels of service. Go ahead, take it away.
So I'm seeing it both on the telehealth side and also on the in-person side. And the problem I have with it is ever since the 2021 said time or medical decision-making, it's so interesting how the time meets the minimum every single time. So for a 99215, they're meeting 40 minutes, and for a 99205, they're meeting 60. Never 42 minutes, never 65 minutes. It's always the minimum. And then when they added you can also include non-face-to-face as long as it's on the same date, I actually have providers saying, well, I really only spent 23 minutes face-to-face, but the rest was preparing my chart, going over records. They've got the spiel down. So what I do in my audits is I also look back and see how many times have they said the exact same thing in every single record. And 9 times out of 10, it's a templated, entry. So we've had a conversation, and what I do, and I can wrap it up this way, is if they met the time, we don't have a choice but to give it to them. But I'll say, but if I looked at this from a medical decision-making standpoint, it's either moderate or low or whatever it turns out to be. So I give them the choice, and then I recommend how I would have submitted it. That way it's on them. I'm like, you may have technically hit your time, but I don't believe it. so here's what it should be.
One thing I will say, I'll say 2 things, right? Going back to the 2021 guidelines, for my providers who are heavily relying on time, when they changed 99214 to 30 minutes, I felt like they should send a letter to the patients like, good news, you're going to get an extra 5 minutes this year.
Yeah, right.
But I say something very similar to you, Terry. I try to look at the note. I try to go back and look at the old note and see what was, carried forward, how they word the language. And the thing that I've always said, and I say it even more now, is when you, in my belief, based on both what you're documenting and what you're saying, when you deviate from medical decision making and the assigned code, and you're deviating upward using time at the volume that you are, your documentation on the surface may support it, but you are taking an additional compliance risk. And so if you feel like, you want to take this documentation into the payer review and go at it with them, that's the risk you're taking. And it's both in terms of the volume and the style, because time, regardless of what we say about time or medical decision making, like I always, to some extent, think of time as outlier circumstances where you're deviating from medical decision making, and there's a good understanding of why. And I've even said to providers, look, if you're talking about this includes the time I spent writing this note, there's always a medical necessity component. And if my dad was a police officer like 30 years ago, and I'd watch him type his police reports, and he was like a one key guy. He was like, and if you, and you're exposing yourself to risk, and you just need to be thoughtful about that.
Right. And I always tell them too much of a good thing is too much. You need to be careful with those level 5s, and also be careful with time, because we all do the math. I want to see your scheduler. I want to know why you had 17 level 5s, but you're only in the office for 3 hours today. And so,
That's
do
right.
the math.
That's right. Keep in mind, the government is looking at what they refer to as the medically unbelievable day. So if you have more hours for billing than there are in the workday, you're going to have a big problem, and you're going to have to answer to that. But the last thing that I'll say, and then we'll wrap this segment up, the payers are using these programs that are called cloning sluices, where they're, to Scott's point and to Terry's point, they're able to take a look at trends in language in your documentation. So they may ask for a chronological order of services for a particular patient. So as opposed to doing 20 different patients, they may do 5 patients and ask for 5 dates of service on each of these patients. They can look at the language to see how many times you have given that same statement again and again and again. And that's what assists them with diminishing the level of risk. And I've seen it in a number of criminal trials that I've been a part of. I've seen it in a number of FCA civil cases that I've been a part of. I've actually now seen it for the very first time 2 weeks ago in an administrative hearing. So, folks, heed the advice of these extremely gifted, these well-versed compliance, auditing, coding, and billing professionals that are on today's program. Again, I want to say thank you so much to Christine Hall, to Terry Fletcher, to Scott Kraft, to Stephanie Allard, each of you for taking time out of what I know is an incredibly busy schedule, especially Scott and Stephanie, because I usually throw everything onto your calendars. So with that said, Christine, Terry, Scott, Stephanie, thank y'all so much for being on this compliance roundtable today. I can't tell you how much it means to me. And I am sure that all of our listeners feel the same way. And the one thing that I want to finish out with is this. Keep in mind that it's not the complexity of the patient overall, it's the complexity of the encounter. And I was actually going to claim that for myself, but I can't because it belongs to Terry Fletcher. So with that said, thank you all for tuning in and logging on and hanging out with us just for a little while. Until tomorrow, be good to yourself, but more importantly, be good to